my travel from Bahawalpur around 1000 kilometers and going back, after 1 hour is worth after listening this beautiful talk by Professor Khattak. I think it was an eye-opener, and this is something we must all ponder. I'm sure we are going to have very elaborative discussions on different aspects of cancer. I'll not take much time. I'm not going to show you a lot of slides about the meta-analysis or pathophysiology of cancer, rectal cancer. I'll just leave you with one take-home message. And that message is that one of our teachers and our mentors in surgery told us that Allah subhanahu wa ta'ala has packed our organs in envelopes. And these envelopes are the facial coverings. And a cancer surgeon especially has to understand those facial covers, because anything which is within that facial cover is resectable. So, many people are actually doing breast surgeries. If we can remove the morphological and anatomical confines of the breast, that is the envelope of it, from the clavicle up to the 8th rib, from the midline, from the mid-axillary line, and along with the pectoralis fascia and all the skin, that means we have taken the whole disease out. The same holds true with every organ of the body. Now, this was specially noted with rectum. Rectum has got an envelope which is called mesorectum. And anything which is within the mesorectum, if we take it out from outside the mesorectum, that means we have cured the disease. So, for practical purpose, to me, there are 3 types of rectal cancers. Obviously, morphologically and stage-wise, we can discuss them in different parameters, but there are basically 3 types of rectal cancers. One is which is resectable, one which is not resectable, resectable with the curative sense, and one which can be made resectable. Now, if we have MRI or CT of the pelvis, we have a rectal tumor. If we have a black rim around it, and that black rim is jet black, that means this tumor is resectable, because the tumor is not coming out of the confines of the rectum. Now, if, for example, if it has gone outside that, it is not resectable with a curative intention. And if that black area is non-homogeneous, it has got white specks over there, that means it can be converted into a resectable one by giving a neoadjuvant therapy. Now, see, the point which I want to just discuss with you in our 10 minutes time is that since that outside that confine is a normal tissue, so APR, which is a standard operation for carcinoma of rectum, is essentially an operation which is performed in a normal tissue plane. So, if you have done a proper case selection and you do APR, actually you are dissecting in a plane which is actually a normal plane. It is just like removing a normal rectum. So, if someone says that I did a curative operation on a carcinoma of rectum, but it was very difficult operation, probably he selected a wrong case. Now, with this understanding, this procedure can be much easily performed laparoscopically as compared to open, because your dissecting plane is actually a normal plane. It is as if you are removing a normal rectum. So, I'm sure yesterday, you came to know that there are 5 units over here, and a lot of good work is being done. So, our senior, this will not be something new for our senior colleagues, but our residents and junior staff is sitting there. So, I would like to show you a video, and rest of our talk will be on video, where one standard APR is performed. And that actually demonstrates that a person who can do laparoscopic cholecystectomy, a person who's doing diagnostic laparoscopy, and a gynecologist, for example, can do some ovarian work. The learning curve for laparoscopic colorectal surgery is actually not very difficult. And if you are familiar with those instruments, laparoscopic APR can be learned much easily because we are working in a normal plane. So can we run that?